Yeah, we can hear you.
Okay, great. Okay. Hope you all enjoyed your Saturday off, and we're doing here on Sunday. Saturday is usually a clinic day for us. We averted a small little catastrophe here with some giant event, so hopefully it'll be quiet for now. If not, we'll figure out what it is. So you got off? What is that? Okay, so I don't know if some of the stuff that's going on in the group chat, I don't know if that's meant for me, but if it's a particular question, just try to identify it as a question to us rather than the group so we know. So the usual sort of contact information, and we're not going to be monitoring our email during this. So if you have something to send to us, please send it, if you want to send it privately, you can send it privately through the chat by just specifying who you want it to go to. Because we won't be monitoring the email. So let's talk a little bit about the mechanics of what's going to happen today. So it seems like the consensus is that you want a fairly strict breaks. I had written down 20-minute breaks halfway through each segment, and I had changed that to 10. I don't know why that didn't pop up on mine, but the consensus was from people, there were some complaints about the 20 minutes. So we will take the 10-minute breaks every hour. So that means we'll break at 9:50 and then resume on the hour. So we'll be 50 minutes at a time. So we'll change that to 20-minute, 10-minute breaks. Okay. So the questions, cases, and quizzes, I think there was some confusion. We should have made that more clear in our last lecture. That these sorts of fast-paced quizzes are really common in the psychiatric community or the medical community, where you're not really expected to answer. You're certainly not great on it. Nobody's looking at them. They're just a way to get your sort of fast test yourself about, what your knowledge base is. And when I do a pre-quiz, there's a quiz before even a lecture occurs, you're not expected to know anything. And in fact, the less you know, the better in terms of what I'm talking about, because it really says to me that, okay, this is something that you really need to this will be beneficial for you. So there are, in my presentations today, there aren't any quizzes, but there'll be a case that we follow all along. The case is the case of Susan, and that is posted for you if you want to have that up, but I'll also be reading it on the lecture. So Dr. Papp will have these quizzes. Again, nobody's looking at the answers except we can see. The only thing we see is how many people have responded, and we get up to about 80%. That's a good lot of you, and then we go from there. So in terms of the chat, it's really helpful if you have comments amongst yourself, like I mentioned, to confine those just to yourself, because it's difficult for us to respond to every question otherwise. And then if you have extended questions, particularly if the questions are not about specifically about our lectures, but more ethics and that sort of thing, we'll respond via email later, or you can talk with other faculty members who are doing that. Dr. Myers, no, I am located in San Diego, and so is Dr. Papp. The exam is going to be open book, just as it was last time, 90 minutes. There'll be, I believe, 15 questions this time, since it's only a one-day class. And then we'll do the same thing. The study guide will be provided after the lecture. There's also, it's called an activity. I've never done it before. It's new, I think, to this year, that you're having to complete between, on a weekend. So Dr. Papp and I have next week's, and it should be posted. I don't know if it's posted now or it'll be posted by the end of this lecture. But when I had asked for you to send me your questions, the article that you had chosen, the not bulk of you, but the most popular article was about ketamine. Brady, I'm not sure. about that. If there's a class, we were told we were supposed to post it, so it's posted, and I'll just let the administration go with that. Maybe it's supposed to be the following week. That's what we were originally told. So it's posted, and you can do it whether the administration wants you or not. But it's about ketamine, and since there was also again, assignments are only if we have no classes. We were told that we were supposed to post that. So, and again, quizzes. These aren't quizzes when they show up on our lecturing. So we were told to post a thing. If you don't have to complete it, then don't do that. So, but we were told that there was common to have 3 quizzes, 3 question quizzes. It's just 3 questions about the article. So I'm not understanding what the questions are going on in terms of the chat. Is there a specific question for me? So if it's not required, you certainly don't have to do the quiz, just. So Brady, you don't have to do the quiz if it's not required. It's just posted, and if you want to do it, it's up there. It's about ketamine. It's about psychopharm of ketamine, so it's an interesting article. All right.
Doctor, sorry if I also jump because I noticed people mentioned about next week having class. Next week, apparently, for the conversation we have, and you are also aware of it, the last information I have is that instead of actual class, we have videos on your section on 16 and on Dr. Estrada's section on 17 that people need to watch. And there are some online activity that they need to do based on that videos that they watch. These are recording from previous years that people are expected to watch.
Okay, so I didn't know that. Again, there's another article posted. Most of the questions can be answered without it. Don't do the quiz if you don't want to do it. Do it if you want to do it. So, but I do think ketamine is a fascinating topic for all of you. So here's a little outline of what the lectures are going to look like. So I will be lecturing first about the trauma response, diagnosing it, and the secondary response from a trauma. And I'll be briefly talking about the neurobiology, but Dr. Papp is going to go into that in great detail in the second part of this, the second lecture. Then I'm going to be giving a treatment overview, and with PTSD, the treatment is not, it's a little more complex than just doing pharmacotherapy. And then Dr. Papp will be talking about the pharmacotherapy of PTSD, which, if you don't know already, is pretty minimal in terms of what is considered to be specific for PTSD. And just sort of the difference between the PTS versus the depression approach. The depression, in terms of medication, there's a vast number of medications that are specific for depression. And with PTSD, it's going to be far more about identifying particular symptoms that go along with the particular presentation of the response to the trauma. And so it's going to be much more about the integration of psychotherapy with the medications. So it's not going to be probably as intense, or a vast number of medications, again, for depression that had to be covered, but Dr. Papp will not be covering as many medications. Before the depression exam, I don't know how many of you have taken it at this point, but I had suggested that all of you find some great, really nice source that you can look up medications quickly. I just want to mention a couple of them again, and I think is important. And some of them are free, and some of them cost a little bit of money, but probably the one I like the best, that it costs some money, it is Stahl's Prescriber's Guide. It's about 1 inch thick, and you can look up every medication ad nauseum. It's got the little pearls. It's got some of that art of psychiatry that's difficult to pick up, but it's a great resource. It's something like $60 or something like that, but we actually have one in each of our clinic rooms. So the other one I had mentioned was Hippocrates, which has a nice online one. It's free. I think there's a version of it that you can buy that's it costs. And then lastly, I don't know if anybody's talked to you about it, but John Preston, whose class we took over, so he used to teach the PTSD and the depression lecture. Well-known guy, he wrote Psychopharmacology, Ridiculously Simple, and other books. But on his website, so it's John Preston, PsyD, you can get a copy of his 2-page prescriber's guide. It is posted on Moodle with the other postings, and you can look at that. It's just 2-page. It's got starting doses, the different classes, and it's now, I believe it's Brett Moore, who's also one of your faculty, is also on that little guide. So it's great. I mean, when I took this course, I had that thing printed out with me, and I'd make little notes on the side, and I think it would be a good thing for all of you to have. And if you lose it, it's really easy to find again. You just go John Preston PsyD, and then you can pick that up. In terms of learning objectives, again, the learning objectives were taken from past lectures that we gave and others gave, and what APA considers to be needed in order to become a prescribing psychologist, or just to be well-informed psychologist, knowing about psychotherapeutics. At the bottom of this screen is a website that shows the APA what they expect to, sort of the objectives they want you to learn in terms of psychotherapeutics, which I think is useful for all, and psychopharm, right? So, are there any questions at this point? Okay, so let's move on. So trauma, again, and when we're talking about PTSD, we're certainly talking about trauma, is a shock to both the mind and the body. So current thinking in trauma is not just about what it does to the brain, but what it's going to do to the peripheral nervous system, and how it's going to, the body is affected as well. So most of the, much of the new work is about trying to integrate body techniques along with brain techniques. And I know some of you are very well versed in trauma, and this may be sort of repetitive for you, but hopefully it'll give a little bit different perspective about how psychiatrists or physicians are thinking about PTSD. So by the APA, trauma involves events that pose significant threat, physical, emotional, or psychological, to the safety of the victim, loved ones, friends, and are overwhelming and shocking. So they're in the traumas categories. There have been some that have added, some have been taken out in the DSM-5. But the categories that they have right now are combat acts of terror, natural human disasters, etc. One of the ones I think is the very most important to understand right now is this other category. So the other category is going to involve things that you may not even consider to be traumatic when you first think about it. For example, a severe psychotic episode, whether it's a brief psychotic episode or even something like schizophrenia, can cause trauma, humiliation events, bullying, loss. They are all cause a PTSD. Trauma is this emotional response to just a terrible event. So, but bottom line, how an individual experiences an event really depends on very complex interaction of things. It's not just about the event itself, but it's about the nature of the individual. So with the nature of the event, there's going to be the complexity, intensity, frequency, and duration of the event. And the individual themselves is, what is their individual variance and interpretation of the event. the traumatic reaction really implies that that event was traumatic to that person. So the treatment of specific symptoms of the traumatic response does not exclude patients with subclinical diagnosis of PTSD. So even if you can't make a diagnosis of PTSD, does not mean they're not having a maladaptive response to the trauma, and it's those symptoms that you're going to treat with either psychological techniques or with medication. So this response to the traumatic event, there's this sort of normal adaptive response to the trauma, and that's not going to create a PTSD or acute stress disorder, but there's a maladaptive response as well. And so the person that has obviously has the normal response is not going to develop full-blown PTSD. And just doing this a different way, we thought it'd be better, but I just take a minute to reset my slides here. So the normal and adaptive response to a traumatic event isn't a disorder. I mean, that's what we're supposed to do, respond to a traumatic event. Almost anybody who experiences a traumatic event will experience PTS. So there's chat going on about CDCR. Is that anything to do with me or our okay, so maybe those sorts of questions could be confined to the student body because it's a little distracting for me to see it. It would be a lot better in terms of the flow of it. Because I think there's a button for you can just scroll down. It says to everybody, or you can say what students you want to refer to. The traumatic stress really has a dramatic effect on both the sympathetic nervous system and the parasympathetic nervous system. So it says it is not possible to choose student body. You can maybe just select people, but okay, so let's just do it this way. I will pause occasionally and then you can ask a question. I'm just gonna not be able to follow what's going on here on the chat, okay? All right, so this traumatic stress is gonna have a very dramatic effect on both the sympathetic nervous system and the parasympathetic nervous system. Intrusive memories and autonomic arousal can happen within hours or days, but it doesn't mean that fear is going to have to be present at the time. And most traumatic events, there's going to be symptom resolving within a few days. In a normal adaptive memory processing, the memory just replays, sort of modifies the emotional response to the trauma, and hopefully will increase some sort of tolerance for the traumatic content. So when it's processed and replayed in the memory, it loses its impact. The preoccupation may be part of sort of adaptive mechanism to avoid future events that can be harmful. Memories are then transformed into more organized narrative of the past, explicit memory rather implicit memory, and then it's affected by our own cognitive schemata. It's accessible to our conscious awareness, so usually there is not sort of an amnesia profile with it, and the recall of it doesn't overwhelm, so you can think about the trauma and not be overwhelmed by it. Minimal sensory information is included, so unlike a traumatic response, there's going to be, you're not going to be feeling it, hearing it, seeing it, and then it's going to fade and change with time. Are there any questions about a normal response? Okay, so the maladaptive response. So if the sympathetic nervous system is overwhelmed, there can be a freeze state. And if you haven't read the article by Stephen Porges, Orienting in a Defensive World, it's a fabulous article. Are there people who are not aware of it? So has everybody's seen the Stephen Porges work? Yes, it's in, okay, not everybody's seen it. So yes, it's in the reading list if you want to read it. It's pretty short. So Dr. Papp will talk, I believe he talks more about Stephen Porges. Maybe not. So the idea is, and you'll see it in the slides down here, is that that when there's a trauma, sometimes the sympathetic nervous system can be so overwhelmed that a third state goes in, and this is a parasympathetic nervous system freeze state. And he sees it as the polyvagal theory. So it's a different part of the vagal system that creates a freeze response. And this is expected to be sort of part of what happens in a dissociative state. So the freeze state, there'll be, a drop in heart rate, loss of sort of awareness of the environment. So it's a pretty brief article. And it is what much of current trauma work is being based on, or it influences a lot of the current trauma work, particularly body work. Also the biofeedback, there's a lot to do with the Stephen Porges. So I suggest you read it. It is not required. Nothing in the reading list is required whatsoever. It's just for your benefit if you'd like to know more about it. So within this freeze state is this altered state of consciousness. Again, this is what dissociation is associated with. It's preparing the body for camouflage or pain. And permanent brain changes can really occur with this sort of freeze state. It's considered to, in this case, the trauma is considered to be an information processing disorder, where with altered states of consciousness, numbing, time suspension, reduced awareness, depersonalization, amnesia. It can be, a protective if something really bad is happening, but unfortunately it is not associated with good outcome in trauma. Okay. So this sort of summarizes it here. The disordered fear regulation and development of PTSD. There's going to be stress sensitivity, over consolidation of the fear memories and reaction, a generalization of the fear cues, and impaired extinction of the feared memory. But again, the resilient stress state is someone is more stress resistant or resilient, recovery from it, and discrimination of fear cues, so they can tell what is a trauma related to the trauma itself versus a trigger, and the normal extinction of fear memories. I won't go into this in great detail, but you can see what parts of the brain. I think Dr. Papp will talk about how the brain is affected by a trauma, but the fear response, hippocampus, amygdala, prefrontal cortex are all affected in PTSD. Let me just check with Dr. Papp. Yes, he's going to be going into this. So again, this is just a brief introduction to it that he will be talking about a little bit more. So the maladaptive memory processing of the traumatic event is going to be an overwhelming arousal which interferes with the memory processing. There's going to be a limbic system overwhelm where the orbitofrontal cortex is affected. The visual cortex increases. The locus coeruleus is activated, and yet the prefrontal cortex and the Broca's area are reduced. So the Broca's area, of course, is the speech area, and this is sort of the mutism that can happen with trauma. People who are severely traumatized, and I've certainly had them in my office, can barely speak sometimes, particularly if they're going into sort of a dissociative state. You have this speechless terror. And that's because the Broca's system actually goes offline, and a narrowing of consciousness. There's a neurohormonal release that affects how the memory is stored. So it's not stored in a normal way. It's not transferred to the hippocampus properly. And we talk about it more as a implicit memory rather than explicit memory in this case. So this maladaptive memory processing of the traumatic event will create extremes of remembering and forgetting. So they're going to remember some parts of the trauma with great complexity and with great clarity, but there may be complete amnesia even of some of the parts of it, or of the whole event itself. You treat the emotions as a memory rather than just something that activates the memory. these memories are stored in disconnected fragments of sensations, emotions, behaviors, and memories as an implicit memory, not as a coherent, integrated narrative of the past. In fact, there may be no fixed narrative at all, and it's hard to make meaning of it, of the details, and maybe completely ego-dystonic. So there's a construction of, over time of these fragments, sometimes in a non-integrated way. Are there any questions about this part of what we're talking about? Again, Dr. Papp will go over brain changes in more detail. So let's talk about diagnosis. So these are the three major symptoms. We're going to look for the clusters for the diagnosis of PTSD or traumatic stress reactions. Diagnosis is important in that, first of all, not just as we mentioned before, the insurance reimbursement, but in order to really target the symptoms and know what medications are going to be appropriate. So the incidence of PTSD is pretty frightening to me, considering up to about 9%, 6 to 12% of people are going to have some level of PTSD in their lifetime. It's one of the most common psychiatric disorders, and I can tell you in my own practice, and I treat a lot of trauma. The more and more I ask, the more and more I find traumas in the past. The highest is going to be, of PTSD will be in people who have suffered with rape, combat, captivity, internment, genocide, but it doesn't rule out other people. Huge number of veterans, so clearly the VA is very interested in PTSD, and there are some studies that are coming out, like the VASD. I won't be covering that today, but are looking more at PTSD. The highest is in Latinos, African Americans, and Native Americans, and higher in women. So during this lecture, we're going to be following the case of Susan. So Susan is, this case is, I think I got all parts of it, it's posted. If you want to see the whole case, we're going to sort of be picking it apart in order to see how we treat this. So Susan is a 51-year-old teacher who is brought into your office by her neighbor. 3 weeks prior, Susan found her husband hanging from the living room ceiling fan. Susan's neighbor found her on the floor next to the body, barely responsive, a ladder fallen by her side. The neighbor took Susan to the bedroom where she curled up on her husband's side of the bed, mumbling that nothing was real. Susan was the primary caretaker for her husband who had bipolar disorder. 1 month earlier, her husband had been charged with a crime and was released on bail. Susan struggled to find the money to pay for his defense. As the eldest daughter of neglectful, alcoholic parents, Susan had learned how to be a good caretaker, although she felt depressed, stressed, and trapped by her current role. All of their friends and family had abandoned them due to the nature of the alleged crime. So now what we're going to do is look at Susan. Thinking about Susan, we're going to talk about the pre and the post and peri-traumatic risk factors. So pre-traumatic risk factors, so what's happening before the trauma happens, which especially during childhood, there's going to be genetic and neuroendocrine difference between people. So low cortisol responses to stress is a pre-traumatic risk factor. And clearly other health, mental health issues, especially if those mental health issues happen before the age of 6. Personality factors will affect it. How resilient is the person? What are their attachment and coping styles? No one coping style is correct. Sometimes, for example, you think about somebody who's in a prisoner situation, it's going to be very different sort of a response to the, it'd be a different sort of pre-traumatic risk factor than one in battle. Social support and cultural factors are very important in terms of how the trauma is interpreted. Minority, female, young and old, socioeconomic status, education, intelligence all factor into some of the pre-traumatic risk factors. The peritraumatic risk factor, so that's basically what is happening at the time of the trauma. Clearly, the state of the individual is going to be important. If somebody is highly stressed already at the time of the trauma, they're going to have a different sort of response. Dissociation at the time of the trauma, this is pretty important to know, dissociation at the time of the trauma is the single most predictive factor of developing PTSD. How the individual is able to react during the trauma, whether they can flee or they can act or react, is going to play a role. So if the person is basically trapped, it will encode even stronger the trauma. So that's a risk factor if there's a trapped sense at the time of the event. So this nature of the event, the severity, the perceived control, and perceived threat are all going to play into it. So the degree of control, for example, how expected was it, how prepared they were, how sudden was the event, and how much control could they take. And the perceived threat, is it personal injury, interpersonal connection, threat of somebody else. So they're all part of the nature of the event and the severity. So it includes both the severity, how close it was, so the proximity, the complexity of it, intensity, frequency, and duration. So they're all part of the peritraumatic risk factors. The post-traumatic risk factors. So subsequent stressors, I mean, are they going to be in a protective environment afterwards, or are they going to be re-exposed to the trauma? So re-traumatization is pretty common in a lot of treatment. Adverse life events, are there going to be financial, interpersonal loss that are going to affect the individual? And what are their coping strategies? Like as I mentioned, there is no single coping strategy that's best. For example, passive coping strategy in captivity can actually be beneficial. But a good support with external locus of control is the worst outcome in one study that I read. So that's, even if you have good support with an external locus of control, it can be a bad outcome. The social support that one receives after the trauma and the level of social engagement is very important. Non-judgmental support is protective. Negative appraisals by others can be significantly worsen the response. So blame, rejection, i.e. sort of bad things only happen to bad people, shame and secretiveness are all going to play into it. But certainly the cultural syndromes and idioms of distress influence expression of PTSD in the range of comorbid disorders in different cultures. So now, the most predictive of developing PTSD from the slides that we just saw, coping, self-efficacy is an important factor. Of course, yeah, absolutely. Most predictive of developing PTSD are dissociation at the time of trauma, acute stress disorder without treatment, prior traumas. So if there was an interpersonal loss in the prior year, that's going to be predictive, and what was the level of social support after the trauma. So let's, are there any questions, first of all, that, and then we're going to look at Susan again. No questions. Okay. So here's the case of Susan again. So let's look at what her pre-traumatic risk factors are. So there's no, you don't have to do a quiz or anything, just if some people can tell me what they remember to be some of the pre-traumatic risk factors.
Give me a slide so you can read.
We'll go back here. All right, so we've got trauma history, caretaker, husband with bipolar, neurobiology. Good. Okay, so let's look at what some of her pre-traumatic risk factors, child of alcoholics, right? So she was a caretaker, she had financial stress, she had legal stress, so she's already sort of set up for this pre-traumatic effect. She had a lack of social support. Remember, she said that everybody had abandoned her because they believed that her husband had done it. She was female, which right there is not going to be it's going to be sort of a strike against her. And then likely prior trauma. So she was a child, right, of alcoholic parents, which a number of you mentioned. So, and this husband with bipolar, where she was caretaker. So those are some of the pre-traumatic risk factors. Let's look at the peri-traumatic risk factors. I'll go back again. So what happened at the time of the trauma that may have been affected her? So any ideas? All right, dissociative response, entrapment, absolutely. Anything else? Poor coping, freeze state, good. All right, so we've got some good ideas. So again, these little quizzes and things are just to try to get you thinking. And it looks like people are, obviously people know about trauma, but some of you maybe more than me, but it's good. So here are her peri-traumatic risk factors. So there's likely dissociation. We're not sure, but it sounds like there's a dissociative state. She was trapped. So there was either a freeze response or medical. So she's trapped there. And then the event, clearly there was close proximity. So she found him there. It was severe, he's dead, unexpected, and it was a strong interpersonal connection. So those were what happened at the time of the trauma, which really made it worse. We're going to continue with Susan throughout this, my lectures. So are there any questions about that at this point? No. Okay, so let's look at the DSM-4. So it was classified as an anxiety disorder, and there were 3 core symptom clusters of re-experiencing. Someone asked if this was a real case. It's actually a real case with a few minor changes. It's actually a case of mine. Okay, so she's it was classified as an anxiety disorder, and there were 3 core symptom clusters: re-experiencing, avoidance, and numbing, and hyperarousal. But as we know, things changed in the DSM-5, so it's no longer classified as an anxiety disorder. Is this trauma and stressor related disorder? And so do I think it's related to anxiety? Absolutely. And I think the placement is in the DSM-5. So someone said DSM-5 has updated 4 clusters. Yes, we will go to the DSM-5 in a second and see that. So, this it is clearly closely related to an anxiety disorder, and I think the placement in the DSM-5 really shows that. So, within the trauma and stressor-related disorders are reactive attachment and disinhibited social engagement disorder in children, adjustment disorder. Which I don't know about you, but I sure got a lot of diagnoses that are adjustment disorder. And then acute stress disorder and PTSD. Acute stress disorder, I'm just going to briefly talk about. So within the DSM-5, oops. Just had trouble scrolling this guy here for some reason. There we go. So within the DSM-5, we've got 4 clusters. Avoidance, and this is for age 6 and over. So there's avoidance, negative cognitions and mood re-experiencing, and hyperarousal. So the recurrent involuntary intrusive memories, there needs to be 1 symptom within that cluster. Avoidance of stimuli associated with trauma, 1 in that classification. Alterations in cognition and mood, 2, and alterations in arousal and reactivity. And then there's going to be a subtype of dissociative. The newest DSM-5 eliminates the immediate response to trauma as involving fear, helplessness, or being horrible. Okay. So its most really prominent clinical characteristics is this anhedonic and dysphoric symptoms, externalizing aggressive symptoms, or dissociation, for when they sort of change these symptom clusters. So the clinical presentation can be very confusing for both patient and clinicians. So at least when they're in my office, something just doesn't make sense. They may not talk about the trauma or want to talk about the trauma, which is pretty common, but their story just feels sort of off, bizarre. It seems sometimes or often incongruent with their affect. They can be sitting there smiling and talk about how miserable they are. And it's really important to start querying the different categories that are often missed in terms of what you might think of as PTSD. So for me, I almost always query medical illness, because a high percentage of the medical and mental health patients have had trauma experience, either directly or indirectly, relating to their reasons for seeking treatment. That's the APA at the top there. So I ask them if they've had car accidents. So first of all, I ask, have you had trauma? And many people say no. Then I say, have you ever had car accident? Have you had medical trauma? I always ask, has there been a suicide in your family? So that's where I find a lot of the life events checklist and CAPS can clear it up, absolutely, except that, some of us, it depends on, how much time you have and what is really your, sort of your mode of how you do therapy. I often find that the life events checklist they don't even fill that out for some of these things. So the key questions that I'm going to ask them about their symptoms are their hypervigilance. I often ask them, where do they sit in a restaurant? And then very often it's that they sit with their back against the wall. Heightened startle, dissociation, and sleep. Those are, for me, the key things. I mean, everybody else, everybody's going to have their own key questions that I think are important for identifying trauma, but PTSD, those are what I use. But it's really important to not miss the subclinical. You know what, I missed one of my slides. I apologize. I missed acute stress disorder. So let me just go back. Do you see this one now? I apologize, I skipped ahead. So acute stress disorder. Very, very similar categories to PTSD. This post-traumatic response that's going to affect the functioning 3 days to 1 month. So after they've had it 1 month, then we can consider PTSD. Most reactions are going to remit spontaneously within a month, very similar to PTSD. And for acute stress disorder, they're going to be intrusions. The criteria, you need 9 symptoms from 5 categories of intrusions, dissociation, negative mood, avoidance, and arousal. The thing that is different than PTSD, that it doesn't include non-fear-based symptoms such as risky or destructive behavior, overly negative thoughts and assumptions about oneself in the world, those sorts of things. And that dissociation is not a specifier. It's actually one of the symptom criteria that can be included in the 9 symptoms that need. So again, my apologies for skipping forward on that. So again, now back to the PTSD. It's very important not to miss this subclinical. So let's go through each of the symptoms. And again, the reason this it is really, very important in terms of being able to understand the symptoms well is because when you're thinking about medications to treat PTSD, you're thinking about treating symptoms rather than just the disorder. I mean, that's really the case in almost anything that you're going to treat with depression or bipolar. You're still going to think about this particular symptom presentation, but this is particularly true in PTSD. So intrusive thoughts are going to be recurrent, involuntary, and intrusive distressing memories of the traumatic event. And in children, this is repetitive play. You'll be having a whole class on on children. So I don't have any claim to know much about children and trauma. But there's really no extinction of the intrusive thoughts. There can be flashbacks as sort of dissociative reactions where the individual feels like they or act right in the traumatic event were occurring. They may occur on a continuum with the most extreme expression being a complete loss of awareness of the surroundings, but it doesn't have to be complete. And these reinforce the traumatic memories. Nightmares, so the nightmares can be repetitive. Sometimes it's the event happening over and over again, but it can be sort of, it can morph into other categories as well. And then after the person thinks about the reminders, there's going to be this emotional stress. So again, we're talking about usually a hyper-reactive state, but sometimes it can be more of a freeze state as well. So this physical reactivity after the exposure to the traumatic reminder, odd body symptoms. There are a lot of odd sort of body symptoms that people with PTSD talk about, such as tingling and spasms and heart racing, that sort of thing. So something that I've seen are things sort of like a pseudo seizure sort of presentation. Often I find people experience in the abdomen, sort of a tightening of the abdomen. The avoidance of the trauma-related stimuli. So they're going that includes just thinking about it. So they're going to avoid thinking about it. They're going to avoid thinking about it, and the external reminders to it of the events as well. They're going to organize. Some people organize their entire life around the traumatic memory, and once you start doing that, there's less social support. It can develop into a phobia of the memory processing. I had one case where she had been raped and she had not left her house in 4 years, and so there was no sort of ability to be exposed to it. The third symptom categories is significant negative thoughts. Again, this is not within the acute stress disorder, as many of these sort of significant negative thoughts. There may be inability to remember the trauma. Time disoriented happens, confusion, fragmentation of the memories, and exaggerated negative thoughts. Decreased interest, feeling isolated, detached, and estranged, and the negative affect where they really can't experience positive memories. Dissociative subtype here is this level of dissociations that can happen at primary, secondary, tertiary. Oops, I skipped one. Excuse me. Trauma-related arousal and reactivity, irritability, risky, destructive behavior, hypervigilance. So this hypervigilance is going to be one of your key things to be looking at when you're treating patients for medication. Heightened startled, difficulty concentration, and difficulty sleeping. So you can see a lot of sleep issues in the PTSD population. I was hoping to finish this before our break, but I'm not going to be able to. I guess I had to do some introductory stuff. So dissociative subtype. There are going to be different levels of dissociation, primary to tertiary. And with the subtype, there are going to be flashbacks, amnesia, emotional detachment. And this sort of curve here that you see is what we're talking about, having this shutdown or parasympathetic kick in, what Porges describes as the polyvagal theory. So it's part of the parasympathetic shutdown. So are there any questions at this point? Hopefully this is a review to most people with a few things. So we've got this sort of secondary maladaptive symptoms that start to emerge. So 80% of those people who suffered PTSD have met a criteria for at least one other mental health disorder. There are going to be maladaptions that emerge to deal with this dysregulation and blunting of physical and emotional pain. There's often a loss of a sense of self, and this is actually what may bring the patient into therapy. There are going to be a lot of comorbidities of substance abuse, depression, and anxiety. So the behavioral adaptations are start to develop to block out the memories of addiction, overwork, risky behaviors, etc. I often see people with sort of a alexithymic state. They have sort of a faulty stimulus discriminations with this hypervigilance. The social disruption can be extreme, reenactments of the trauma, poor ability to rate, fear of being alone, faulty, again, this faulty stimulus discrimination. So all sorts of maladaptions begin. I'm just going to do one more slide and then we're going to take a break. They develop a particularly negative view of life with hopelessness and despair, a lot of guilt and blame. I think this is the primary symptom I see within patients is guilt or blame, and an existential crisis and some enduring personality changes can happen. So in terms of the medication piece of it, these physical and neurocognitive issues are very important. So there are going to be increased health problems and early death. There are lots of somatic complaints that people have when they have PTSD detached from the body. You may see a lot of pain presentations, changes in posture. There can be weight instability, often with a sharp decrease in weight at the beginning and sometimes a weight gain later. Sleep disturbances, so I see often like a early morning wake-ins, like 4 or 5 is pretty common. They're just not going to be thinking very well. They're going to have these memory issues and concentration problems. Just less stress sense. The stress sensitivity is going to be higher, so they're not going to be able to tolerate as much of a stress as some people. But these somatic complaints, and I think this should be one of the things that you're really looking for in terms of symptoms to help you diagnose, are these sort of diffuse somatic complaints or specific somatic complaints. Are there any questions at this point? Okay, so let's go ahead and take a 10-minute break. We'll meet here again at 10:01. The ability to talk to everybody or individual students. So in the past, I was looking at it, it looked like you could just choose which people you wanted to talk to. It looks like not. So if you wanted to go ahead and have your chat, that's fine. And I'll just now and then go over and ask if there are questions. So again, that was my error. I thought that you had the choice of student, but you don't. So let's talk about complex PTSD. It's a type of trauma that occurs, everybody can hear me? Yeah, okay. So it's a type of trauma that occurs repeatedly and cumulatively, usually over a period of time and within specific relationships and context. So this is not within the DSM-5, but it is in the ICD-11 during personality changes as a result of catastrophic events, disturbances in affect, self, interpersonal relationships, and it's persistent across time. Pervasive across different situations. It's likely to be, I'm sorry, I have to look at something. Yeah, so this is generally associated with childhood trauma, attachment issues, and vulnerability. It is not my area of expertise, complex trauma, although I see it often. I do more single event PTSD, but I certainly see it in my population. There was one study, in a study of 4,000, that their participants reported 3 or more types of trauma were almost 5 times likely to be at risk for a psychotic experience as well. So it comes with a lot of sort of comorbidities and other sorts of symptoms. It's really clear that individuals who have been exposed to a trauma stressful event can exhibit a phenotype in which really, rather than anxiety or fear-based symptoms, the most prominent clinical characteristics are anhedonic and dysphoric symptoms, externalizing angry and aggressive symptoms, or dissociative symptoms. And this is what is associated with complex PTSD. So let's look at the difference between PTSD and complex PTSD. PTSD and complex trauma are distinct groups with different antecedents and different levels of functional impairment. And so these are there are certain characteristics that are common to both PTSD and complex PTSD, such as the re-experience, avoidance, and hyperarousal. But in complex PTSD only, there's going to be affect dysregulation, so angry outbursts, more negative self-concept, for example, worthlessness and guilt, and more interpersonal disturbances, so not feeling close or detached. So Eddie said, anger outbursts and complex only, really? So this work, I agree, absolutely. Do we see anger outbursts in PTSD, but it's more stable over time? So we're gonna look at it here. So the work, much of this is done, different individuals who are studying it. This is a great little thing here. So we're gonna see more affect dysregulation. So in this, here's sort of these low symptoms. So this is what a more general population would we have, or somebody who's with low symptoms. Complex PTSD is blue, and the PTSD is red, and we can see the affect and anger. Certainly, we've got symptoms that are higher than the low symptom categories, but it's lower than the complex PTSD. And then we can see here the affect, so the sensitivity, self-worthlessness, self-guilt, interpersonal, feeling alone and attached, they're higher all in the complex PTSD. And here the symptoms are, fairly similar in this area. So these are more dreams and flashbacks, thoughts, behaviors, hyperarousal. So does that make sense? So yeah, absolutely anger we're going to see in PTSD, but it's not as severe, at least in this study. Everything's based on studies, but in general. Does that make more sense about the anger? Ready? Okay. So this is a nice little, so there's overlap. You can have both this, so PTSD, complex PTSD, borderline personality disorder, or borderline personality disorder plus PTSD. Yeah, so everything has controversy in it. I agree. I'm presenting one sort of perspective. This actually came out of the latest conference that Dr. Papp and I attended, talking about how these things overlap. And so, one can only go on what the most current things are going on. So again, this was presentation. Actually, it was somebody from PTSD, from the VA. I can't remember his name. His name is, a lot of this work is, I'm sorry, I can't grab the name. Not this particular study. I apologize, I don't have his name on the, Murray Stein. Murray Stein here at the VA talked a lot about this sort of complex trauma work. So here we go, sort of the complex trauma versus borderline. So in borderline, borderline, they have some things that look kind of the same. There's more emotional dysregulation, fear of abandonment, unstable sense of self, impulsive behaviors, and in the complex trauma, there's going to be more nightmares, but there's a lot of emotional dysregulation. So they're definitely overlap, but some little bit differently, and in terms of how, I work with people, I don't care quite so much what their classification is if they have the symptoms. So again, I'm thinking more about the symptomatology. Here's another little symptom endorsement with complex PTSD and borderline. It's a little more difficult to see this graph. We have the borderline plus complex PTSD. That's this. I think you can see my cursor, I hope. Can you see my cursor?
Yes, we can.
Okay, all right, thank you. So this is this borderline personality plus complex PTSD. This is obviously the highest here. This is complex PTSD. So I'll let you just look at this yourself, but I think it's a nice way to sort of think about how the symptoms overlap and how some are a little bit higher than the others. Again, this is the same researcher. distinguishing PTSD versus complex PTSD. And we can see here that the complex PTSD, this blue line here, has 33% that also present with borderline. PTSD, the red line here, fairly low of 15%. So certainly the relationship exists, but what the numbers are, the percentage of it is clearly controversial and depends on who's doing the study. So we're going to go to the case of Susan again. After the neighborhood, and so we're going to continue with this in my next presentation. And then we're going to have Dr. Papp in between, but I wanted to give you sort of the next step to be thinking about. So after, well, let me stop again. Are there any questions about let me go back to this. Any questions about PTSD, complex PTSD, and the borderline? Again, there's an overlap, it's unspecific, but I think it's useful to see. Okay, all right, so again, this case of Susan. So after the neighbor came to check her on her 2 days later, Susan was taken to her HMO, where a therapist was also authorized to give her one crisis session. There she was told that she must recount the trauma to get better. After this session, Susan became more dysregulated, often screaming with terror and grief, especially in the early morning. She shook with fear and had pseudo seizures. So pseudo seizures are, they can have all the sort of physiological sort of cascade that looks like it from the outside, but not the same brain activity. She could not sleep more than a few hours at a time. She had hallucinations of her dead husband and continually monitored the environment for the police. So I'm going to leave you with this. So this case, and we'll revisit it then when we do the third lecture about treatment. And I'm going to turn it over to Dr. Papp now. Give me just one minute, okay? So just a 2-minute little break, just while we redo it, so.
Okay, good morning, everyone. So we have a different system, and so we are not covered. You see our slides nicely, and everybody is, well, the Zoom chat and participants are separate, but we have a different way of switching slides. I hope it was not too confusing. So we're going to talk about the neurobiology of PTSD a little bit. Specifically, somewhat about the genetic influences, the anatomical structures, and the neurotransmitter systems that are associated with PTSD, in order to get some kind of a baseline understanding, like a neurobiological understanding or neurobiological view of the abnormal learning mechanisms that seem to underlie and characterize PTSD. And these learning mechanisms are increased generalization, so the generalization of the original trauma memory. So not just the actual memory or actually memory of the actual event, but anything that looks like, even remotely, is going to evoke the response, the trauma response. The deficit in extinction is a second abnormality in the learning mechanism. When you have ASD, acute stress disorder, then your response gets extinguished due to non-reinforcement. But in PTSD, I'm sorry to hear myself back, so let me take a little break and see what's going on.
It's coming up. Okay. I did mine.
Okay, sorry about that. So the third abnormal mechanism in learning is the enhanced acquisition and consolidation of the trauma-related fear. There are 30 to 70% heritability factors for PTSD that different studies show. There are several genes involved, like with any kind of psychiatric condition. And in addition to the genetic influences, there are epigenetic changes which occur in early child development, and certain genes are upregulated and certain genes are downregulated, and this remains pretty much unchanged for the rest of the life of the individual, providing additional risk factors for later development of PTSD. And of course, like in any other condition, there's an underlying genetic variability that conveys baseline differences in resilience. It is clear that not everybody gets PTSD, even though they're exposed to may have been exposed to the same trauma. And why some people do not get PTSD. Actually, most people do not get PTSD. So most people have some baseline resiliency in the genetics, and only a few people are, statistically speaking, will develop PTSD under the same kind of trauma. One of the gene systems upregulated in PTSD is related to the immune system. And it looks like it is something that gets upregulated in many other conditions. Recently, we talked about the depression. And in depression, we also see the upregulation of the immune system. And there are some studies, of course, to try to use that for treatment. So far, with not much success. Sorry. So what are the epigenetic changes that we see in brain development? In some of them coming from animal studies, and some of them are coming from human studies. We can see there's a reduced cortical volume, reduced neuron or glia density, and it is seen in maternally deprived rats, infant rats, but it can also be seen in abused and neglected children, whether they have PTSD or not later in life. So just as depression is neurotoxic, abuse is neurotoxic. And the problem is that it occurs such early in life that it is more difficult to turn back than something that occurs much later in life. Another structure of the brain is the corpus callosum, and there are some sexual differences in terms of what causes decrease in size. neglect in boys, and sexual abuse in girls seems to lead to a smaller corpus callosum size. And again, that's something that remains true for the rest of the person's life. But in opposition to adults, there are no anatomical differences that develop in subcortical structures, such as the hippocampus or the amygdala. Hippocampus is, if somebody wonders about it, is sometimes considered subcortical because it's physically under the cortex, but sometimes cortical because actually it's a cortical structure, even though it's sort of like an old version called paleocortex. And you can see that in see that this is in contrast with adult findings. This is called high cumulative life stress, when it occurs in early childhood. For instance, exposure to severe marital conflict or severe chronic illness in a close family member or friend. Another area of epigenetics is the hypothalamic pituitary adrenal axis. One of the changes that have been observed is the chronic elevation of the my old slides here. So corticotropin, let me just write it here. Corticotropin releasing factor from the hypothalamus, which leads to an enlargement of the anterior pituitary in abused children. And again, that's something that remains for the rest of the person's life. The severity of these changes correlate with the severity of the trauma and whether trauma occurred before or after age 5. In adults, there's also what we see is lower cortisol levels and attenuated. There's a weakened response to cortisol, but this is what you see in children. The neuropsychological effects of early high cumulative life stress, so exposure to conflict or disease in family members or maltreatment, compared to socioeconomically similar controls, causes lower IQ, causes deficits in language and academic achievement, and executive deficits. And again, this is both with and without diagnosable PTSD later in life. To demonstrate that cumulative trauma leads to neuropsychological problems that are not necessarily related to PTSD symptoms, but they later serve as risk factors for the development of PTSD symptoms. Clearly, someone with a lower IQ and develop deficits in executive function will have more difficulty dealing or processing a traumatic experience. The neurobiological effects of adult trauma. Trauma exposure sets off a cascade of changes that culminates in a state of the amygdala being hyper-responsive to reminders. This is one of the key findings in the brain science of PTSD. One of the ways it's being accomplished, so to say, in the brain is inadequate top-down control, both by the medial prefrontal cortex and by the anterior cingulate. These are structures in the brain that's supposed to put a dampener on the amygdala, but these structures are under functioning in adult PTSD, and they allow the amygdala to overreact to traumatic reminders, whether it's internal or external. This kind of increased amygdala activity during fear processing prior to treatment is associated with poor treatment response, poor response to CBT. One of the reasons why adequate management of anxiety during therapy is required for CBT to be efficacious. Again, in adults, inflammatory system kicks in as a result of PTSD. Says, I'm a bit confused. Are you saying there are subcortical changes in adults, but not in children? Yes, that's exactly. So children are, most changes are cortical and corpus callosum, which is part of the cortical system. And in children, these are not affected, at least not under 5 years old. After 5 years old, they begin more and more respond like adults. So again, high levels of pro-inflammatory cytokines can be detected, and they remain elevated during the course of PTSD. I just a few days ago read a study that was supposed to be actually a treatment of depression with these anti-inflammatory agents that are nowadays used for the treatment of different kind of like lupus and stuff like that. And they seem to have some antidepressant effects, but they have some really adverse side effects, such as creating cancers in patients. So I guess this is not something that is going to be used in psychiatry very soon. Okay, any other questions about this really basic summary of what happens in the brain as a result of trauma? Okay, so here's one of your favorite things, a little quiz. So which of the following plays a role in the consolidation of episodic memory? And Aiden, do we have these quiz things up? Aiden? Well, I guess not. Then just if you just type the number in, that would be great.
You did for people on their phone.
Yeah, most people said B, and that's correct. Hippocampus is a structure that plays a role in consolidation and the consolidation of episodic memory, among other things. But of course, as we saw at the depression slides, it plays a role in the maintenance of depression. So look at the medial prefrontal cortex. This is one of the best researched areas of the brain, and one of the areas of the brain that have has the clearest changes associated with PTSD. The medial prefrontal cortex is related to learning, association between context, locations, events, and corresponding adaptive responses, particularly if these are emotional responses. Don't forget, this is part of the default mode network. And what we see in PTSD is a hypoactivation of the medial prefrontal cortex upon trauma-associated stimuli. So not normally. So when the person is resting is at the normal, or any other kind of activity, it's functioning normally. But upon trauma-related stimulus, its activity reduces. The reduction compared to normal, the level of this reduction is commensurate with the severity of the PTSD. So the more severe PTSD, the more hypoactive the medial prefrontal cortex upon exposure to trauma-associated stimuli. the level of this hypoactivation is correlated positively with the hyperarousal response with the perceived current threat. And not surprisingly, this hypoactivation is correlated with the hyperactivation of the amygdala. Again, as I said, one of the brakes on the amygdala is the medial prefrontal cortex. So the hypoactivation of this part of the brain will fail to inhibit the amygdala, which is going to be also bombarded by input from other sources when there's a trauma-associated stimulus. As a result of this, behaviorally what occurs is the diminishment of decision-making, worsening of emotional regulation, and the non-occurrence of fear extinction. And what is perhaps more interesting, the most interesting thing, that this hypoactivation in PTSD improves upon exposure to successful psychotherapy. And you know, it's remember this because of when we get to the actual medication part, we'll see that psychotherapy is absolutely not secondary to pharmacotherapy in treatment of PTSD. Actually, to the contrary. So these studies were done with different kind of blood flow studies, fMRI, PET scans, SPECT scans, etc. You can see similar hypoactivation of the prefrontal cortex in generalized anxiety disorder, panic disorder. So just so you know, this is not only in PTSD, but it is definitely one of the most robust findings in PTSD.
Sorry, Dr. I was away for a second from the site. Do we still want to run the poll or the chat room responses?
No, it's okay. That's just fine.
Awesome.
Yeah. So hippocampus is another major, very important structure that's involved with the pathophysiology and pathogenesis of PTSD. As you guys know, it plays a role in episodic memory and also in place memory. So for instance, the mental maps, which may be underlying the reminder sensitivity to certain locations. It is, again, part of the default mode network. It also encodes emotional contact from the amygdala. And in PTSD, what you see is a reduced volume and reduced metabolism. Because, you know, of course, it translates into reduced functioning. It may limit the proper evaluation and categorization of the experience. Again, it would lead to overgeneralization of fear. It is, of course, in the temporal lobe, and it has multiple bidirectional connections to structures like the hypothalamus, the thalamus, the amygdala, and most of the entire cortex. Now, just a quick question. What is the cellular mechanism of learning that is primarily associated with the hippocampus? It's just a little basic neuroscience. Used to be my field of research somewhat, so I'm just curious what people know about it. The cellular mechanism of learning that is associated with the hippocampus. It's called long-term potentiation. Okay, that's just neither here and there. It's something that is associated with the glutamate system involving the NMDA receptors. And again, even though this happens in adults, in children it develops under 5. It develops normally even in. Okay, I know. It's just, well, pruning is a different kind of learning. Pruning is learning by experience. So, and long-term potentiation is learning by association. In long-term potentiation, stimuli that occur together become associated and become related. In pruning, activities that are repeatedly done are going to lead to the brain structures associated with them getting stronger, and other brain structures and other cellular parts of the brain being pruned away. So pruning occurs, let's say if you learn biking, and long-term potentiation occurs if you learn to respond with salivation to a bell. Again, it is just to jig people's brains and nothing. I don't fault people if you don't remember right away, because I'm sure you heard about it before. Another major brain part of the brain associated with PTSD symptoms is the anterior cingulate cortex, and also I forgot that I have to do these things. How do I get this selection? Okay, so you guys see this little arrow thing? Wow. So this is the anterior cingulate cortex. It is involved with certain parts of learning, executive intentional learning, and it regulates emotional, cognitive, and autonomic responses, fear learning and unlearning. So it is functioning well in acute stress disorder that eventually goes away. And it is also a function, part of the brain involved with error detection. It is part of a different network, a salience network, obviously, because it's just from considering that it is associated with error detection, it has to be associated with the salience network. In PTSD, both the hypo and hyperactivity of the system is noted depending on the type of tasks used in studies, and also depending on the person. We're going to see a interesting case study at the end of this presentation that might be related to this. The increased activation of this particular brain structure is commensurate with the severity of the PTSD. It is connected, again, bidirectionally to the hippocampus, the amygdala, the prefrontal cortex, but also to the ventral tegmental area, which is a deep brain structure, which has to do with the reward circuitry, motivation. Clearly it may have, these connections may have to do with some of the behavioral responses that you see in PTSD that are excessive. But also you could see an increased activation in non-trauma exposed identical twins of people with PTSD. So it seems like it may be a risk factor. So if you have a natural increased activation of the anterior cingulate, then you're more likely to develop PTSD. Okay. Questions? The next structure that we're going to be discussing is the amygdala, one of the main culprits in supplying us with the symptoms of PTSD. It is part of the salience network. It is involved with fear learning and selective attention to threat. It is an interesting structure because it shows clear sexual dimorphism. It is larger in males and reacts differently, for instance, reacts differently to same sex versus opposite sex individuals. So men react to women with higher activation, and women respond to men with higher activation of this structure. Females retain stronger emotional memories than men, which may be related to differences in this structure. In PTSD, it shows an increased response to any external fearful stimuli. For instance, to fearsome faces, not necessarily related to the PTSD trauma itself, but just in general. So you could have a car accident, but you will still have an increased response in your amygdala to fearsome faces. Of course, it will show increased responses to trauma-associated stimuli, and in general with negative emotional balance, so even to sad pictures. Just a little bit about the sexual dimorphism. It stops developing about 1.5 years sooner in women than in men. And so it becomes a more developed structure in men, which may be one of the reasons why men are less sensitive to PTSD, given the trauma being equal. And of course, one of the other reasons why women have more PTSD because they tend to be traumatized more than men. But even trauma being equal, females seem to develop PTSD more readily, and it may have to do with the sexual differences in the amygdala. Well, that's a very good question. I thought about it. I don't know. It's certainly something that would be interesting too. I know that there are some studies of neuroscience and neurobiology of homosexuality, but it's not something that I have read about. But yes, it would be interesting to see how it pans out. Is it possible that trauma causes it? Trauma causes what? Arnold, is it possible that trauma causes what? Homosexuality. Well, I don't think that general trauma, and this is simply personal, I have no claim to any kind of expertise in that. I have seen only men who had been sexually traumatized and they ended up being homosexual. But I have no idea whether, and they were sexually traumatized by men, so I have no idea whether that led to homosexuality. There are plenty of sexually traumatized men who do not become homosexuals. I am, again, not aware of any studies because it's not something I usually read about. Any kind of at least comparative studies. But it's certainly an interesting question. There is no causality. Okay, so I'm not sure any studies that show whether there is or there isn't. I think that sometimes there may be, but typically probably there isn't. The last brain area that I would like to discuss is the Broca's area, which is the motor speech cortex, part of the motor system. Its official definition, one of the official definitions that I found, is responsible for applying semantic representations to personal experience to allow its communication or description. I think what it means is allows you to tell you what you feel. Not so much how you feel, but what you feel. PTSD patients can tell you that they feel bad, that they feel horrible, but they may have a much harder time telling you what they feel. And of course, there will be studies, there will be functional MRI studies and PET studies done with the Broca's area. And they found that actually, so when you speak, as opposed to when you are, silent, the Broca's area becomes more active, so it gets more blood. If you do, let's say, an fMRI study with a PTSD sufferer and ask them to talk, and ask them to talk about, neutral topics, and then ask them to talk about something that has to do with trauma triggers, then there is a decrease in the blood flow in the Broca's area, and it basically impedes talk. That's maybe one of the reasons why people sometimes find it unable to describe experiences. And this also may be something that you might consider. One of the reasons why verbal psychological treatments may be compromised by people are actually accessing traumatic material. When you ask them to talk to you about what happened to them in the treatment, and they are flooded with the emotional memories, and this whole system of PTSD kicks in with the amygdala overactive and the Broca's area becoming underactive, then they will have a hard time talking. And sometimes, as Dr. Myers described, that people just become mute instead of talking. They are unable to talk. And biologically, this may be the mechanism by which this is happening in the brain. Okay, questions? One thing that I haven't found, just to mention something why it's not here, is the hypothalamus. I haven't found any really salient studies that would have shown something really replicable with this brain structure, which is really remarkable because of how prominent sleep disturbances are in PTSD. And of course, sleep is a function of the hypothalamus. But there's really no studies that would have anything comparable in terms of reliability to these 5 structures that I've mentioned. But again, I'm sure that there is something major going on in the hypothalamus with the trouble sleeping and the nightmares. And something finally about the autonomic nervous system. Dr. Myers already mentioned the name of Steve Porges, and this is in summary his theory, which is called the polyvagal theory. The polyvagal theory describes 3 levels of threat detection, and no link between trauma and sexuality. Okay. So the autonomic nervous system is the peripheral part, is the way the periphery plays part in PTSD. All these things, the medial prefrontal cortex, the amygdala, the Broca's area, they will determine observable behavior in terms of almost like interactive kind of behavior. But as far as how the body is going to respond to the PTSD or to the trauma itself or to the reminders of the trauma is determined by the peripheral nervous system, which is, of course, the autonomic nervous system. And, we know that there's 2 major varieties, the sympathetic and the parasympathetic nervous system. And sympathetic would be the flight system, and the parasympathetic would be the rest and digestion system. So this is the simple version, simplified version. But according to the polyvagal theory, there's a third system, which is a part of the vagal system, parasympathetic systems. According to this theory, it was the parasympathetic system that developed first during the genesis of the vertebrates, and then came the sympathetic nervous system, and in the highest vertebrates came the second parasympathetic system. The stage one is the basic. The comfort system is the mammalian vagal system. This is the vagal system, the autonomic system that developed in mammals, and this is what dominates when you are resting, watching TV, eating, etc. Stage two is the defensive mobilization, which is the fight or flight response. The sympathetic nervous system dominates. So when there's social comfort, then you have your blood pressure goes down, your digestive system goes up, you feel relaxed. When you have defensive mobilization, then things become different. The blood is shifted away from the guts, shifted towards the brain and the muscles. Heart rate goes up, blood pressure goes up. You become more alert. And then the stage three is defensive immobilization, when the behavior shuts down. It is when the original primitive vagal system begins to dominate according to this polyvagal theory. So when you're exposed to threat and you can deal with it, then you are in stage two. You are in a state of defensive mobilization. When you become unable to get out of the situation, when the defensive mobilization, the flight or the flight or the fight fail, then the only thing remains is basically to play dead. And that's when the defensive immobilization comes in. And then when the primitive vagal system overcomes the activity of the sympathetic nervous system, and the organism becomes basically looks like, for instance, when the animals play dead, that's when, according to this theory, the defensive immobilization kicks in, stage three. Now, obviously, in humans, you don't really see people just totally playing dead, but you see that in certain levels of PTSD, certain levels of threat, when the person is not able to either flee or fight, then eventually this kind of behavior gets sort of brought up in the individual. You're going to see that there's going to be a reduced heart rate variability. There's an increased recovery time. I'm sorry, I just saw something here. Oh, it's a link? Okay. All right.
Almost for break.
All right. So in adults with PTSD, the behaviors and processes are consistent with being in a state of chronic mobilization and or withdrawal. And depending on your ability to deal with the trauma, you either mobilize yourself or withdraw. And that can be something that later occurs in exposure to reminders. So some people have an activating response to reminders, and some people will have an immobilizing response to reminders. So in some people, stage two, or defensive mobilization, will dominate in exposure to reminders, and in some people, stage three will dominate. And so that's why you see that PTSD is not a single symptom presentation much more variable than depression, because you can have a PTSD patient who is extremely active, and you have a PTSD patient who is almost immobile, and they're suffering from the same condition. Okay. So yeah, so we're gonna break in.
No.
Oh, sorry, we're gonna break now. I'm sorry. So we break right now.
So 10 minutes.
10 minutes. I apologize for not breaking at the hour. Dr. Myers apparently signaled to me, but I didn't notice that, so it's my fault. Go back to this slide for a few more minutes. So see that the autonomic nervous system has a role in some cardiovascular changes, the reduced heart rate variability, which is seen in PTSD, but it's also seen. Do I have my? Sorry, need my. It is seen in also as you age, your heart rate variability goes down. So one of the ways it is being is evaluated, and with respect to PTSD, that it may be causing an accelerated aging, or at least it looks like accelerated aging, because the heart rate variability is reduced as if the person were 10, 20 years older. And also Dr. Myers mentioned that there is more, there's higher incidence of medical diseases in PTSD, and one of them is cardiovascular diseases. And again, that has to do probably with the chronic activation of the autonomic sympathetic nervous system. The startle response, the physical peripheral manifestation of startle response, the physical peripheral manifestation of hypervigilance, and the physical delivery of aggression all have to do with the sympathetic nervous system. And I just want to make sure that it's clear that these are not clearly separated responses. A person can have both at the same time. One may predominate, or the other predominate, or may go from one stage to another. So just be aware of the fact that these are not clearly, cleanly separated responses. And it can be even very confusing for the person to evaluate his or her own mental state, because both can occur at the same time.
Don't worry about it.
Okay. So let's look at just a little quick quiz. I'm sure everybody's going to get this. Which of the following is a catecholamine? Okay, we hit 80s. That should be good enough. Yeah, so dopamine is a catecholamine. Dopamine, norepinephrine, and epinephrine are the catecholamine. Histamine is not a catecholamine. Ketamine is obviously medication, and tryptamine is an amino acid derivative. And it is not a catecholamine. And I just see another poll here. I guess I don't need this, right?
Well, it's a tendency to do.
Okay.
You can move it over.
I can't move it.
Okay, do you want me to run the attendance as well?
Okay. All right, can I continue? Okay. Okay, so I guess I'll continue, but I have this thing in the middle of my screen and I can't get rid of it. Can someone?
Doctor, you can use your, if you're using Mac, you can use Command and Tab just to switch between the page that is popping in front.
Okay, it's not working. Can you get rid of it because it's not working for me. Okay, now. So the next, so we're going to see the involvement of the catecholamine system. The epinephrine, dopamine, and norepinephrine. This system is activated by the amygdala. It controls the flight or freeze response. Findings that suggest a significant role of this system are the following. The level of urinary catecholamine products positively correlate with duration of trauma and the number of dissociated symptoms. So catecholamines get metabolized by certain products, which fancy abbreviation 5-HIAA, etc. Doesn't matter, and they get eventually secreted in the urine, and there's a higher level of these urinary catecholamines in people with exposure to trauma, and the level of these urinary catecholamines, which again, the metabolic products of catecholamines in the brain, positively correlates with the trauma and the number of dissociative symptoms. Another finding that suggests the involvement of the catecholamine system is the COMT enzyme, is one of the enzymes that metabolizes catecholamines, the other one being the MAO. There's a certain point, the enzyme, where if the person has valine instead of methionine, the enzyme is more active, and these people metabolize the catecholamines more rapidly. So basically, they have less catecholamines in their brain available, and people with this particular variant of enzyme run a higher risk of dissociative symptoms in victims of childhood abuse. So it is another risk factor. So this was the catecholamine system in general, and now I just lost my little, okay. And here specifically the noradrenergic system. The control, the center of the noradrenergic system is the locus coeruleus in the brain, one of the structures in the brain stem. The stress-induced release of norepinephrine from this locus coeruleus is critical for emotional memory consolidation, and the locus coeruleus is associated with, is connected to the amygdala. You can inhibit this effect by using propranolol. It can impair fear conditioning. It can attenuate the emotional response to traumatic memories, but it does not actually impair their recall. And knowing this, there were studies that, and I'll talk about later in the second, in the actual the medication section, that there were studies done with giving propranolol to people right after trauma. And yes, you can develop, you can reduce certain symptoms right after trauma, but there is no effect on subjective symptom severity or severity of PTSD, or whether PTSD will develop or not in the future. Again, you can see the effect of the noradrenergic system by seeing that there's increased heart rate, increased skin conductions, and increased facial muscle electrical activity to trauma-related stimuli. And these can be also all blocked by beta blockers such as propranolol. The role of the serotonin system. The serotonin system, obviously, as we'll see, plays a major role in the development of PTSD, because the main medications that we use for treatment of PTSD is serotonergic medications. Nevertheless, specific studies with specific findings, such as the ones with respect to the locus coeruleus or the dopaminergic system, not as easy to come by with respect to the serotonin system. There is some genetic vulnerability, just as we see it in depression, that there's a short allele of the serotonin transporter gene, which is associated with reduced activity of the transporter itself. And there is increased vulnerability to depression in the presence of maltreatment, and that will in turn makes it more likely for PTSD to develop. In some PTSD studies, it was found that there is reduced binding of serotonin by in the amygdala by the serotonin transporter. This is likely why serotonergic medications are effective. Interesting findings that chronic SSRI treatment may impair fear extinction learning. Now, fear extinction learning is obviously one of the ways psychotherapy works for PTSD. Now, these were animal studies. Obviously, it's not going to stop anybody from giving PTSD to giving SSRIs to PTSD sufferers. But as you're going to see in the other section, jiggling this system might, in making sort of counteracting the SSRI effect or SSRI-like effects, may help extinction learning. There are studies that are examined right now at the VA. Okay, some other systems which are more indirectly related. We have one indirect causation known about them, the opioid system. Opioid antagonists increase fear acquisition and block fear extinction. Opioid agonists, on the other hand, reduce fear acquisition. PTSD is the most frequent comorbidity among opiate abusers, so opiate use is very high among PTSD victims. One of the things that you can, when you see a certain kind of drug being abused with people with certain psychiatric conditions, and you can bet that it started out as self-medication, and self-medication was discovered because the drug did something positive, and of course eventually it becomes a problem because the drugs, due to the fact that they're illegal, due to the fact that they're addictive, begin to cause additional problems. But the fact that people tend to navigate towards opioid with PTSD indicates that probably there is some beneficial effect of these chemical agents on PTSD. There's an interesting study with children with burn victims. These are children administered morphine during treatment, during changes of bandages, and is one of the most painful things that you can imagine. Changing a bandage on a burn victim is like huge areas of exposed skin, horrible pain. So actually, many times these burn victims are anesthetized, put on anesthesia, and that's how the bandages are changed, because they have to be debrided, they have to be washed off, antibiotics. So it's a hugely painful thing. And it turns out that there was a follow-up study, and children administered morphine after these burns exhibited decreased PTSD symptoms months to years after treatment in a dose-dependent fashion. So the higher dose of morphine they got, the less PTSD they have later. And just of note, the similar effect was noted when ketamine was administered to burn victims. Children actually who got ketamine had less PTSD than I think I mentioned it in a previous. No. But so children who got ketamine during bandage changes in these burn victims had less PTSD than children who did not get ketamine. And one of the reasons children got ketamine is because they were more severely burned. So even though their trauma was more severe, because of ketamine, they had less PTSD than less severely traumatized children who develop PTSD. The endocannabinoid system, again, one of the drugs that PTSD victims, especially war trauma victims, gravitate towards is marijuana. Again, the reason for that is because obviously it does something positive for the symptoms. Again, apparently it seems to mediate the fear extinction in the amygdala and the medial prefrontal cortex. It seems to facilitate the extinction of conditioned fear in humans. Again, these are neuropsychological studies. And finally, the oxytocin system. There is some data that show that there are decreased levels of oxytocin that have been found in women exposed to early emotional abuse. Here's a summary slide of the interaction of these systems. So again, I lost my little cross here. So as you see, there's a pre-existing sensitivity, the genetics and the environment, the genetics, the epigenetics. Then comes the learning of fear, the traumatic event, consolidation of fear, and then the expression of the fear. And that's when PTSD develops. That's the nightmares, the flashbacks, etc. That's the expression of the abnormally learned fear response. And these are different kind of medications that can insert themselves into the different processes and help with the either non-development or the treatment of PTSD. So as you see, morphine is between consolidation of fear, and this is where also ketamine would work. It would simply reduce the likelihood of PTSD developing. Once PTSD developed, then you can have these different agents such as THC, the alpha blockers, and SSRIs. We can talk about the alpha blockers in the next section. These are basically reducing the symptoms of PTSD. And the beta blockers would help with the over-consolidation. And this is where this is what maintains PTSD as a chronic condition. And this is what disappears when acute stress disorder diminishes and eventually disappears. And these are the different kind of other therapeutic processes that I'm not qualified to talk about. And we'll talk about the alpha blockers and SSRIs and some other medications in the treatment section, because these are the ones that actually are either approved or without approval being used for the treatment of PTSD. So let's talk a little about dissociative PTSD. Dissociative PTSD is probably one of the most difficult forms of PTSD to treat. People with exposure to antecedent trauma, so there's people who already had been traumatized and then re-traumatized, are more likely to develop dissociative PTSD. People be traumatized during childhood when dissociability is generally high, and the children who dissociate during maltreatment, and this dissociation allowed to occur repeatedly. This allows for the development of an atypical pathway. And if I may just go back briefly to the issue of pruning, this will be a pathway that should have been pruned away because it's not being used during the later childhood, but because it is continued to be used, it is not pruned away, and it becomes permanent. So this would be again learning through repetition, not learning through association. Dissociation itself is related to a number of deficits in a lot of neuropsychological domains, especially in executive functioning. For instance, response inhibition, divided attention, in social cognition, and in numerous aspects of memory. So people who are high dissociators have difficulty working memory, autobiographical memory, especially autobiographical memory, which can be completely jumbled due to the multiple dissociative events that eventually create their own memories. Functional alterations in dissociations. You can see the reduced activation in the anterior cingulate cortex, which is part of the salience network, and as typical for PTSD, you can see a reduced activation in the medial prefrontal cortex during trauma triggered reliving experiences. And there's dissociation with numbing, which is even more severe form of dissociation, which comes with depersonalization. There is also reduced metabolism in the right temporal lobe. There's increased metabolism in the parietal lobe and occipital lobe. And there's a hyperactivity of the dorsal basal complex, which decreases in blood pressure, metabolic activity, and heart rate. Despite already elevated levels of circulating adrenaline, which is just another word for norepinephrine or for epinephrine. And that's when the primitive parasympathetic response dominates, that's when it kicks in as per the Hall-Vagal theory. So in humans, the typical manifestation of the activation of the third level of trauma response, when the ancient parasympathetic system kicks in, is a numbing dissociative response. There are not too many studies in the treatment of dissociative PTSD. Some involve psychotropic medications, some involve biofeedback. Psychotropic medications would be either SSRIs or antipsychotic medications, and no studies have been demonstrated any kind of reliable efficacy. And there's some indication from literature that highly dissociative PTSD has, in general, poor response to any kind of treatment, whether it's medication or psychotherapy. And finally, I would like to present a real-life example of differential traumatic reaction. This is a really very interesting article. If you want to get it, it's in the bottom. You can find it. Actually, it might be even uploaded. So this is a case of a couple, a husband and wife, who were trapped in a car in a multi-vehicle accident. And during this, they witnessed a child in another vehicle burned to death. And they feared for their own lives. They both developed PTSD, and later they were participants in the study. And the study was that, they had, I forget now what was the brain imaging study. I think it was fMRI. So they were put in the fMRI machine, and they were exposed to reminders. So to see the difference between the husband and the wife, I keep losing this thing. The husband had a primary dissociative response. He relived the experience. Upon the exposure to the reminders, he had elevated fear, increased heart rate, so he had a level 2 sympathetic response. And he had an increased activation in the anterior cingulate cortex, increased activation of frontal and temporal lobes. The wife, who had a numbing or secondary response, probably a level 3 vagal response, upon experimental exposure to reminders, had no significant change in heart rate. So whatever would have happened, it was suppressed by the elevated activity of the vagal system. And she had increased neural activity, confined areas to the parietal occipital juncture. So this is just a little demonstration of how the exact same trauma two people, I mean, certainly the one as a woman was a man also probably made a difference because there are differences in the brain structures that are involved with PTSD. But even the same condition, the same diagnosis, the same trauma, within two different people would have different eventually would result in different neurobiological responses. Okay, so again, the response of the husband is, if I may just go back to here to just review it quickly, it would be this would be a stage 2 defensive mobilization response, and the wife's response would be a stage 3 defensive immobilization kind of response, the primitive vagal system. Okay, so that's the husband's response, stage 2, and that's the wife's response, stage 3. Okay, any comments, remarks, or questions about this? All right, then finally, let's have a little quiz. Identify the two statements about the neurobiology of PTSD. Let's try to get to 80%. One more, just one more. Please. Okay, just kidding. So we have 76%. Most of you guys responded correctly. Suppression of motor speech area may interfere with PTSD victims' ability to benefit from verbal forms of psychotherapy. I think some of you guys must have been confused by the last slide, where the husband had an increased activation in the frontal lobe. It just said frontal lobes, didn't say medial prefrontal lobe. It's it's just not exactly the same thing. So, and that's a single study. So the studies show that specifically the medial prefrontal lobe in PTSD has a reduced activation in response to reminders of trauma. In PTSD, the amygdala shows increased response to trauma-associated stimuli, and stage 3 of threat detection is defensive immobilization, when the primitive vagal system dominates and not stage 1. Okay, so again, don't be confused by this real example slide. It did not specify the medial prefrontal cortex. It simply mentioned the frontal cortex, and it would not negate the finding that typically it is the medial prefrontal cortex that shows decreased activity upon trauma reminders in PTSD. Okay. Well, yeah, in the next section, in the therapy section, I'm going to mention a few interesting studies that are trying to enhance this process by adding different kind of medications. Some of them are actually pretty surprising, but so we'll get to that point. Okay. So, all right. So at this point, we can take
look at the case of Maria over break if they want.
Okay, Dr. Myers will tell you a few things.
Since we're supposed to take a break at 12, I don't want to get into the next section. It doesn't make any sense. So if you just look at the case of Maria over lunch, and then you can come back, you have until 1 o'clock. So we'll see you at 1 o'clock. All right, bye-bye.